by a force greater than ourselves, which has sparked our passion for this field and has inspired us to do what we do. And I believe there is no greater inspiration than to serve and do the best that we can for our patients in our own way, in our own corner. However, I have to admit that I find it more fun and enjoyable to work with others in a team. I hope that today's Spinal Cord Injury Symposium will only be the beginning of getting all of us in SCI medicine at University of Michigan together. We've all been working in our corners, separate from each other for too long. I think you all agree that it will be nice to know what everybody else is doing, not just by chance, not just on the surface, but a little more deliberately and a little more deeply. It does give us the opportunity to get to know each other professionally and also personally, making our ties more meaningful. There is strength in numbers, and coming together as the SCI team, SCI group, I believe we can all accomplish more as a team and a group than we ever could in our own individual corners. There is so much to do to get us all under one umbrella, but I am happy that we have this good start. Today, I do want to emphasize the critical importance of bringing all clinicians and researchers together for collaboration in the field of SCI and within our own home, University of Michigan. This collaboration can result in more effective, patient-centered treatments and interventions. When we all come together, clinicians and researchers alike, we can pool our knowledge and resources, develop evidence-based practices more efficiently. This not only leads to improved patient outcomes, but also enhances the quality and safety of healthcare delivery. As you know, this synergy between the groups is essential for forging ahead, advancing medical knowledge, improving patient care, and ultimately saving lives of people with spinal cord injury. With this said, please enjoy the afternoon, learning and getting to know each other. And I truly look forward to more of this with all of you. So welcome to the 2023 Spinal Cord Injury Symposium. And thank you for being here.
And I am delighted to introduce our first speakers, Dr. Noelle Carlozzi and Dr. Carrie Werner, speaking on the impact of blood pressure dysregulation on the health-related quality of life of persons with spinal cord injury.
All right, great. Thanks, everyone. So we're going to be talking about a study that we're kind of working on, two of us plus some colleagues over at in the New York Bronx VA, looking at blood pressure dysregulation on health-related quality of life in individuals with spinal cord injury. So both of us have a strong passion in this. Dr. Carlozzi I was lucky enough that she allowed me to kind of join on a program that they were already starting. This is something that I see very regularly. As many of you out there know, a lot of these individuals do experience both highs and lows with blood pressure. I just came from clinic, and 2 of my 3, we were dealing with episodes of AD. We just had someone in the hospital that Dr. Shoemaker is here with me that we spent 2 hours with on Friday due to uncontrolled high blood pressures. I think of other individuals I have, including one that comes to mind that hadn't left bed more than an hour at a time because of unregulated hypotension for years. So it's just something that's a problematic and a concern. So something that we wanted to kind of look at a little bit more, especially because blood pressure dysregulation sometimes it's recognized, but oftentimes is unrecognized in regards to both their overall impact, symptoms, and what they can do kind of out in the community. Dr. Carlozzi's group developed 3 blood pressure dysregulation patient-reported outcome measures that we're looking to study a little bit more. She'll talk about those in just a bit. So kind of a little bit of background. So, we know of a lot of cardiovascular challenges that can happen with just about anyone, but when we look at the spinal cord injury population in particular, so you look at protective factors, and my mind and eyes kind of immediately jump to regular physical activity, social engagement. Oftentimes, both of those being limited in our individuals with disabilities, and in particular, individuals with higher spinal cord injuries. When you look at risk factors, again, kind of physical inactivity, jumping down, hypertension, or in our case, kind of uncontrolled, sporadic, intermittent hypertension. On the other side, hypotension, and how that can kind of impact cardiovascular outcomes. Along with depression, obesity, diabetes, we know metabolic disorders are higher in the spinal cord injury population. So lots of issues that we're kind of looking as we kind of focus on blood pressure regulation. This just happens to be kind of an example of one patient with a higher cervical Asia B spinal cord injury, and it just shows both the in the blue heart rate, more importantly in the gray kind of blood pressure kind of fluctuations through the day. And this will make more sense kind of as we talk about autonomic dysreflexia. You see the kink in the catheter, bowel routine, another kink in the catheter, and blood pressure is kind of spiking up. Again, sometimes these being symptomatic, sometimes they're not, and they're just hidden. And what kind of damage is that kind of happening long term? This was a study done by our colleagues over at the VA in which they looked at individuals with spinal cord injury, looked at them kind of over a course of 30 days, and kind of how frequently would they actually have blood pressure events, which could be either spikes in blood pressure or drops in blood pressure, and then also kind of how frequently the symptoms occurred. And if you look at the square white ones being individuals that had very frequent symptoms, so that might be dizziness, headache, pounding headache, flushing, kind of symptoms of high blood pressure, or really dizzy, lightheadedness, symptoms of low blood pressure. But they actually didn't have a whole lot of systolic events that would have, or blood pressure events that would have really necessarily correlated. At the same time, a lot of the red, where there's a lot of actual events, and this is probably the scarier one, but actually very few symptoms. So again, kind of saying, how often does this really happen? How often is it underdiagnosed, or individuals just now aware of it altogether? All right. So without getting into the details, just real quick about kind of why blood pressure is dysregulated in spinal cord injury. People know about the parasympathetic system, the sympathetic nervous system, your sympathetic nervous system being kind of your fight or flight that kind of ramps up your blood pressure, supports blood flow so that we can perfuse both our muscles and our brain. It is supported by the sympathetic chain ganglia, which is primarily found in the T1 to L2 region. And if we think, and importantly, heart is kind of supported by a T1 to 5, and then the GI tract T6 to T11. The heart being important because that's what, if your blood pressure go down, that you need to be able to support and again perfuse important organs. The GI tract plays into kind of AD a little bit. So I think it's important to at least kind of have this in the back of your mind as we're kind of thinking about blood pressure dysregulation. So what is autonomic dysreflexia? It's systolic blood pressure increase of 20 to 40 millimeters of mercury above baseline. That's not otherwise explained. And the short of it is any noxious stimulus, oftentimes the bladder, but it can be other things as well, sore, a UTI, a bowel impaction, lots of things. But any kind of noxious stimulus below that naturally kicks up the sympathetic reflexive system to your GI system, so that T6 to T12 area. And then you get an increased blood pressure, body reads it, tries to drop the blood pressure kind of from your parasympathetic vagals, but it can't shut down your sympathetic nervous system because there's a block in the highway of information going from your brain down, right? Because of the spinal cord injury. So that's why we have these individuals with that are at least prone to these high blood pressure episodes. As far as neurogenic orthostatic hypotension, again, if you have a high cervical injury, in essence, the information can't get down to your sympathetics can't respond, so you end up with low blood pressure. They are not moving, so they don't have their muscles kind of pumping to kind of keep the blood flow up so that you can perfuse, get adequate blood flow to your heart so it kicks out. So anyways, these individuals then kind of end up dropping blood pressure. So those are probably our two biggest things when we're kind of talking about blood pressure events that we're monitoring in this study. That's it. I will pass on to Dr. Carlos.
So I'm just going to talk a little bit about some former research that informed the current study. We developed 3 measures, as Dr. Wernemont was talking about, to assess both low and high blood pressure and spinal cord injury. These are self-report measures. And just sort of I'll draw your attention to the total sample. We tested these new measures in 454 people. This was to allow us to do what's called item banking or computer adaptive test development. So these measures can be administered as a static short form or a smart test, where one item, it selects the next best item based on your previous response. So they're sort of more efficient than traditional static measures, but they have the advantage of not losing sensitivity or specificity at the cost of this brevity. So the three new blood pressure measures that we developed, one is LBP HRQOL, so the impact that low blood pressure has on HRQOL, AD, the impact of autonomic dysreflexia on HRQOL, and the impact of low blood pressure on daily activities. So let me see if I can just give you a couple of examples of items. So for the low blood pressure HRQOL measure, one of the items is I felt confused and distracted while sitting when getting up in the morning, or I felt weak, a lack of energy while sitting when getting up in the morning, or I felt drained while sitting when getting up in the morning. An example of an AD item, I had a headache when my clothes were tight. I felt flushed when I was in the same position for a long time. And then an example of the LBP ADL measure, because of changes in my blood pressure, it took me longer than normal to get out of bed in the morning. Because of changes in my blood pressure, I felt restless. So just sort of to give you a little flavor. And you know, what was really interesting to me was the qualitative work that informed this. Like, we were able to ask people with spinal cord injury what their experience with blood pressure was. And like me, who doesn't ever think about my blood pressure on a daily basis, like, people are very aware of what's going on, and they're in tune with their body and these fluctuations and how they're impacting their daily lives. And so the purpose of sort of the current study is to test these measures and to develop clinical cut points that we can use as screening. They're really designed to be screening measures that can be used, that can tell us when we need to bring in people, or when there might be problems or things going on. We know that blood pressure dysregulation and spinal cord injury is underdiagnosed, especially among non-specialists. So, you know, again, just to give us another tool to help evaluate what's going on and ultimately get people the treatment that they need. So the study itself will enroll up to 60 people with spinal cord injury, T6 or above. This is in partnership with the Bronx VA. So Dr. Jill Wecht there is our collaborator. People come in person for a blood pressure evaluation, and they answer a lot of self-report questions. And then we train them for a 7-day home monitoring period where we send them home with a blood pressure cuff. This blood pressure cuff, which people hate. I'm sure if you've done any blood pressure type study where people have to wear a cuff continuously, it's not comfortable. It's not fun. We only ask for 7 days, but it goes on and off automatically throughout the day. So we can get sort of some spontaneous readings, but we also ask people to sort of click a button and take their blood pressure during certain events where we know that they'll be more likely to have issues. And then at the end of the study, folks send home their blood pressure monitor in the mail. And this is just sort of a figure of that study design. So that in-person assessment takes about 2 hours. And then during the 7-day home monitoring period, in addition to wearing the blood pressure cuff, we ask them real-time assessments of their symptoms throughout the day. And then at the end of the day, we ask them a slightly longer battery of questions. And more specifically, this is just a list of the different assessments that we give each during the day and at night. And as I mentioned, folks have to wear the blood pressure monitor 24/7. So this is a bit of a commitment for folks, but it's only for a week. We began enrollment in May of 2023, and we actually are almost at the halfway mark. So the VA has enrolled 13 participants, and we've enrolled 10 here. We're actually ahead of schedule to complete recruitment, which would be October of next year. And with the final study results by April of 2025. Questions? And I know if somebody's monitoring the chat, I think there was somebody who raised their hand too. But we can take questions. We have a couple minutes. No.
What was the funding source?
So this is funded by the Nielsen Foundation, who support a lot of our research, I'm sure.
I don't see anything about the.
Oh, maybe the hand raising was because they couldn't see the slides.
That was it.
That would make sense. But yeah, so for those of you who are clinicians, please send folks our way. For those of you that are researchers, we'll hopefully be presenting again a couple of years from now with more complete data. Thank you.
Thank you very much.
All right, so I am Courtney Fankhauser. I am a recreational therapist here with Michigan Medicine. I'm in the inpatient unit. I'm also a member of UMAIS. It's the University of Michigan Adaptive and Inclusive Sports Experience. I have worked at Michigan Medicine about 1.5 years, but I've been working as a rec therapist for over 12 years, mainly in spinal cord injury and brain injury. All right, so the objectives for our session today: identify how adaptive recreation benefits participants with spinal cord injuries, identify current adaptive recreation programs offered through UMAIS, and identify future goals for UMAIS. So UMAIS aims to enhance the physical, social, and emotional development for people with disabilities by providing quality, local, and low-cost sports and recreation opportunities throughout the lifespan. UMAIS provides affordable access to a variety of sports opportunities for all ages and abilities. So our goal is to make recreation accessible for all, low cost, free activities for people in the Ann Arbor area and beyond. And we're able to do that with the support of Michigan Medicine and generous donations and grants. So UMAIS programs are designed, organized, and run by Michigan Medicine skilled clinicians. We provide the adaptive equipment and the clinical expertise to ensure that all individuals can successfully participate in recreation. Our board is made up of recreational therapists, rehab engineer, physicians, and then we have skilled volunteers too. We have a lot of physical therapists and occupational therapists that come and volunteer with us, and then also a lot of med school volunteers. So we really make sure that we have great clinicians and volunteers available for our programs. So some of the benefits for adaptive recreation, obviously there are a lot of physical benefits. So improving your heart and lung health, reducing falls, improving mobility, just improving overall health, staying active and moving around. And then again, social and emotional benefits. So making these connections, meeting people that, may be going through the same things that you're going through. Connecting with others, improving social skills, building self-confidence, and getting the chance to go and do something you didn't think you'd be able to do again. That's so rewarding for people. We always say recreation doesn't have to stop just because of an illness or an injury. So why, wait around? We want you to get back into these activities that you previously enjoyed or find new activities, just anything, it might just look a little different, but we still want you to get back into these things that you really enjoy. So our current programming, we have the Wolverines. We are a pediatric wheelchair basketball team that runs every Monday, always looking for volunteers and new participants. We have adult sports clubs starting soon, adaptive martial arts, pickleball, and yoga. So in November, we're going to have a 4-week plan of yoga. So we'll be doing that here in Ann Arbor. Adaptive kayaking obviously runs through the summer. We have hand cycling, adaptive fishing, indoor-outdoor camping, hiking club, which is finishing up tonight, and then adaptive golf and walker soccer. So these are just some of our programs. So you can see up in the top left, we have our yoga. We have wheelchair basketball. It's one of our players. We have our indoor-outdoor camping experience. So we provide tents, we provide all the camping gear and just teach people how they can adapt to these things easily. We have hand cycling. Those have been pretty popular this year. And then our wheelchair basketball team up in the corner. They are a lot of fun. So population served, pretty much any ability, disability, all ages. So we have people as young as 5 all the way up to 80, any age. It doesn't really matter. So a lot of our participants have spinal cord injuries, other physical disabilities, but also we have a lot of cognitive disabilities and other things like that. So like my hiking club tonight, it's a lot of people with maybe autism working on social skills, but then you go in doing kayaking and something else and you'll get a whole different group of people. So it's really open to anybody. Partnerships and collaborations. This is something that we're really amping up in the last year, just trying to be connected with more organizations, get our name out there a little more. We are a chapter of Move United. So we also are working with Bedrock. They are a company out of Detroit. We had UMAs in Detroit. We had 2 events this summer where we went to the Monroe Street Midway and we offered adaptive pickleball, yoga, martial arts, and then like an obstacle course, just teaching people, how to do adaptive sports and adaptive recreation and allowing it to be free to people in the Detroit community. And we are going back in the winter. So we're going to be doing low sensory Santa visits, adaptive winter activities on December 2nd and 8th. So we hope to keep that partnership going. Camp Michigania, Kids Sport, we do a lot of collaborations with them. So we did some consulting this year, teaching them how to make their camps more accessible for people with disabilities. We went up to Camp Michigania, looked around, told them what they could adapt, simple things they can do to make the camp more accessible for people. Dance marathon, that's where our tree climbing comes in and where our kid programs really come in full force. And then here on Clinton Metro Parks, we do a lot of kayaking at the Metro Parks. Hand cycling is done there. So a lot of collaborations. We hope to add more and keep that going. So different ways to support UMAs. We will always take volunteers. Our programs have become very popular. We usually have a waiting list, but we can use all the help we can get. So you just have to be 16 and up. No medical background is needed. We will train you on what you need to know. Background checked and trained. So just contact us for any information on that. And then donations. We are always looking for donations and ways to keep our program running. And so we can provide these free and low cost activities for people. So our overhead costs include our equipment, our staffing, rental spaces. That's a really big one. We need places to run our programs, especially coming up in the winter. We need places for our indoor camping and our sports club. And then food and water, just something that we, want to provide for, anything that will help with our costs is helpful. So goals for the future. Right now we have 13 sports and leisure programs available. Our goals are to obviously increase our programs. So we would love to do some winter programming. Skiing is on the list. So hopefully in the next year or 2. We would love to have an expanded sports club, maybe add some archery. We really wanted to do like a Veterans Day archery program. We just, hope to plan that for next year. We want to do some sensory impairment programming, ballroom dancing. There's a lot of different things we want to add. We just, obviously need support and room for growth. So our goal overall is to increase our funding to allow for more skilled therapy programs, equipment, and covering of the overhead costs. So this is our social media. We have YouMazing and Wolverines you can check out for more information. And then we have our email address. And I would love to show a short video just of us in action so you can kind of see what we're all about.
I've been participating in tennis and it's been a great experience for me.
This was my first time doing the kayaking and I really enjoyed it a whole lot.
It was super fun.
Anybody can participate in sport, regardless of what's happening with their bodies.
UMA stands for University of Michigan Adaptive and Inclusive Sports Experience. We're the premier adaptive sports program at Michigan Medicine.
UMAs provides the opportunity for people to participate in activities that they might not otherwise have the opportunity to participate in because of their disability. And we provide the equipment and we provide expertise and provide the space for that at a low cost and in a local setting.
Being able to get the participants on the water is such a great benefit in giving them access to these recreational opportunities, but also giving them the community and being able to meet people that are just like them or have been in a similar situation to them and really bond and build that community over time.
They have a lot of other people who are wheelchair users. Sometimes it can be hard to find that. I've made a lot of friends, and I am getting better with the sport that I really love.
I do go to like wheelchair basketball games.
Often the child with a disability is going to a sporting event and watching their able-bodied brothers and sisters participating in sport and feeling left out. So this is an opportunity for the child with a disability to participate in sport. What it also does is it shows the families that their child is also an athlete.
Sometimes it's tricky to find things that you can do together as a family, and that's why we love the kayaking and the tennis. They're very professional. There's a lot of options. They make sure that you have a great experience, not only for your child, but for the whole family to participate. So siblings and parents can all join in together. Our volunteers are all either therapists, vetted through the Michigan Medicine health system, physicians, engineers, and just kind of the whole gamut of professionals that would day to day already be interacting with people with disabilities, but they're also volunteering their time with UMAs and providing their expertise for our programs.
So on our really hot 90-degree days, our volunteers are not afraid to get out there and spend time on the water with participants. They're either kayaking in the same kayak, they're taking on extra shifts. They really just are out there to have a good time and make the best possible experience for all of the UMA's participants.
Gloria loves to go outside and then do something with the people. But in a school setting or outside, there is just some limitation. This program, they have understanding and they have passion about our kids.
You want to try some basketball? And possibly some soccer as well too.
Just come on out, just give it a try.
Come on down. Do it.
High five.
Okay, and that is all I have. Does anyone have any questions? Yes.
Wow, you're doing so much.
Thank you.
Where is the funding? Where's the support? Who's leading this in terms of the number of events, the partnerships? I know how much work all.
Yes, it is a lot of work. So we have a board of 5 members. So Sunghi, rehab engineer, myself, 2 other rec therapists, and a physician. So we are the ones that are kind of planning out our calendar year and seeing what we are able to accommodate. You know, some of us are volunteering our time, so it does get hard. As for financial, we are looking into grants and other foundations, trying to get some support. Our biggest thing is covering staffing. You know, we want to find some places, you know, we want to keep our staff around so we can provide these activities. So we do have to be kind of picky about how much we plan in a calendar year, making sure that we're not spreading ourselves too thin, but we really love what we do. So I think it's just worth it for us. And yeah, if you know of any other support and foundations that we can contact for support, that'd be great. Yes.
Does everyone know how to refer patients your way?
Yes, our contact information, the email address, it's PM&R, UMA's TR. Yep, just contact us and we will get them in touch.
And how does this fit along the continuum of adaptive recreation or just physical activity opportunities in this area?
Yeah, so our goal as recreational therapists, we want to, you know, once the patients are here in 6A or in rehab, we want to continue with that out into the community. So this is where we first introduce them to the idea of adaptive sports and get them these resources. And then once they're off the units, they've discharged home, that's where it really, you know, amps up, like they want to come back and do all these activities. So that's when we'll try to really get in touch with them, get them involved, because that's when the recreation stuff really starts. Are there any questions on the screen?
I will say these guys donate so much time every weekend. They're putting on some things, so they don't even get a sign. It's kind of amazing when you see the dedication they have. I went to one of their kayaking ones and we had one of our SCI patients that have been discharged, and he was running March, and I'm thinking, how am I gonna get in this kayak? And we did, and it was so good for him, because it was something he loved before his injury. We got him in here, and he and his wife were sitting there problem solving, oh yeah, we can do this, and if we did this, and if we did this. It was just amazing to see. And if you notice in the video, so he is muscle woman. It was very hard to get back up on the lift where the patient can actually use a sliding door to get out.
That's why we need as many volunteers as possible, because it is a lot of work. It's a full, 8-hour day of moving people, transferring people, but it's so worth it.
One session for the kayaking runs all 8 hours, and we see per session about 15 to 17 participants. And we provide 5 kayaking events throughout the summer and 2 downriver trips in addition to all the other 12 programming. I think at our full year, we see about 700 plus participants. That's on top of all the clinicians and the side of the full caseload. So all of us are at full time at medicine and in addition. So any grants, if you guys want to be on with us for grant funding, you may start in 2016 through donation from Epic through Knockoff Classic was the first $15,000 grants that has now just continued on. Some years we have done golf outing, we've done fundraisers at distilleries. If you want to do a bowling fundraiser with your friends or anything. So a lot of the grants, it's hard to find grants that pay for staff timing, staffing time. And that is really our kind of weakest spot. And I think that is the case for any sort of grassroots programming. So if you want to do your personal fundraisers and solicit donations, that would work.
Yeah. Are there any questions on the chat? Do you know?
Dr. Fankhauser, yes, there is a question from the chat.
Okay.
From PF Anderson, is there information about the adaptive martial arts somewhere? I was unable to find it on the website for you, Maze.
Yes, the website has not been updated, but you can always email me. The martial arts will start after the new year. So you haven't missed anything yet, but it's not on the website. Yeah, perfect.
Thank you guys for your patience and for getting me all set up. My name is Dr. Ted Barrios. I'm one of the fellows in neuropsychology in physical medicine and rehabilitation here at the University of Michigan. I started my fellowship here in 2022, but I actually started working at the university with Dr. Meade back in 2019 as a member of her research support staff. And so my involvement with today's project starts back whenever I started working with Dr. Meade in 2019. And then these are data that we presented earlier this year at Paralyzed Veterans of America. So I've condensed this slide or this presentation from a 45-minute talk at PVA to hopefully it'll be more like around a 15-minute presentation for today's talk. So as I alluded, I am presenting solo today, but there were several other faculty members involved in this and putting this research presentation together, including Dr. Michelle Meade, who is principal investigator of the study from which these data were derived. Dr. Carrie Pilarski as well, who's a rehabilitation psychologist in physical medicine and rehabilitation. Dr. Seth Warchowski, who is a pediatric neuropsychologist in PM&R, and Dr. Jim Kraus at the Medical University of South Carolina. So this project was a multi-site study with our team at U of M and then Dr. Kraus's team in South Carolina. And no disclosures. And these are some pretty broad learning objectives that I'm hoping we'll hit with today's presentation. So diving into sort of the rationale for this study, I think it is pretty non-controversial to say that health management after traumatic spinal cord injury is nothing if not complicated. When we talk as healthcare providers about regimens and strategies and things like that that might be useful in managing all of these complexities after spinal cord injury, it's not as simple as sort of plugging and playing a kind of pre-programmed system or a pre-designed program. It really is up to the people that we're working with to figure out what types of strategies we're suggesting and talking about and how to make those actually fit in their own unique life, in their own unique environment, different things like that. And not only that, but there needs to be a real flexibility in being able to take in a lot of information, a lot of things that are really subject to change pretty quickly and without a lot of notice, and make adjustments and tweaks to strategies, regimens, different things like that on the fly and pretty quickly. And there's a lot of factors that we know more broadly that can really contribute to that flexibility and being able to think flexibly and really be able to be pretty independent in managing some of these complexities after spinal cord injury. And this is a quote that I pulled from a 2005 paper that I really liked because I think it gets at a lot of these themes. So I'm going to read it. It says, effectively functioning in the role of self-manager, particularly when living with one or more chronic illnesses, requires a high level of knowledge, skill, and confidence. And I think that as psychologists, these are areas that we really like to focus a lot of our time and energy because we have interventions and techniques that we can use to actually enhance some of these more psychological factors that we know are really important predictors of self-management and all of the other associated outcomes that we think hang together with self-management. So as healthcare has become less paternalistic, so as doctors have sort of taken a more active partnership role with patients, the need for patients to be informed and engaged in their own healthcare has simultaneously increased. And there was an interesting paper from 2004 that was actually specifically focused on healthcare related to spinal cord injury, and it really broke down different aspects of sort of this paternalism versus patient engagement, which I really liked. And so they sort of presented this on a spectrum, starting with open paternalism, which they described as really doctors saying and telling patients, this is what you have to do, sometimes not even telling patients what it was that was being done to them. Then moving into this sort of more, at least being informed, where doctors are sort of telling their patients what it is that they're doing. Now, this sort of they can always say no is actually a flipped perspective. So this is from the perspective of healthcare providers, saying that, well, our patients could always tell us that they don't want this to happen. So it's more of an opt-out sort of approach where the providers are really kind of laying down a treatment plan. The idea being that, if a patient didn't want to do this, they would tell us no. But again, we know that there are power differentials in that patient-doctor relationship, which can make it difficult for a patient to really voice an opposition or a concern with a recommended plan. This idea of making the right choice, this is something that that participants in this 2004 qualitative study talked about, feeling as if they were compelled or encouraged to make what they considered the right choice by their providers, but a little bit more engaged and a little bit more active and a little bit more consideration on the side of patients, feeling comfortable to actually consider what it is that's being told to them. And then on the opposite end of the spectrum of sort of paternalism, we have active participation, where patients are very actively engaged, they're voicing their opinions, they're voicing their concerns. And as healthcare providers, I mean, I can personally attest to this. I really like it when patients are able to tell me that they don't like something I'm saying, because that means we can work on it. So if I'm, have a bunch of ideas and I'm really working with a patient to implement some strategies or to work on self-monitoring, or if we're working on behavioral activation, different things like that, if what I'm saying isn't really landing with the patient, getting that feedback in the moment is really helpful because it allows us to problem solve beforehand, as opposed to waiting until the next visit where things might not have materialized the way that we had hoped. And these are all themes that those authors raised in their paper as well, and all the benefits of having an actively engaged patient. So I wanted to take a few moments to talk about some previous work that I had worked on with Dr. Meade and a few other colleagues. We were really looking at ideal mental health, sort of positive psychological outcomes after spinal cord injury. And there were three factors in particular that we found really hung together with positive psychological outcomes after spinal cord injury. The first being social self-perception, subjective health ratings, and marital status. And there were a number of other factors that did not hang significantly with this. So a lot of physiological factors, neurologic level of injury, injury completeness, number of secondary conditions, education, household income, and employment status. So we were really intrigued by the factors that did hang together with psychological flourishing and some of the factors that didn't. And one idea that we had was that maybe healthcare engagement is related to some of this. Maybe some of these factors are hanging together with healthcare engagement, and that's a really important contributor to ideal mental health after spinal cord injury. Now, in that project, we also segmented our larger sample into a group of folks that were really high on our indicator of psychological flourishing, And we took a really close look at that group of people to try and see if there was a kind of a prototype or some characteristics that might be really important for doing well, sort of flourishing and thriving in the years after injury. And things that we found were that the folks that tended to endorse really high levels of psychological flourishing on the scale we used in that study had generally intact executive functioning. They had strong social support, and they had what we would characterize as a resilient personality. So that informed this project where, again, we really wanted to look at some of the factors that might be contributing to healthcare engagement, independent self-management in the years after spinal cord injury, thinking that this is going to be something that probably hangs together with ideal mental health, positive psychological outcomes after spinal cord injury. So in this project, or in this specific study, we sought to identify the extent to which participants in this project engage with their own healthcare. So what sort of is the lay of the land of healthcare engagement among a group of people with traumatic spinal cord injury? And then similarly, as I was just talking about, what's the association between some of these fixed and modifiable factors with healthcare engagement? We hypothesized that participants would be pretty heterogeneous with respect to healthcare engagement. And similar to some of our previous findings, we hypothesized that more of these modifiable factors would be more strongly associated with healthcare engagement than some of the fixed factors I just touched on a second ago. So as I had alluded to earlier, this was a multi-site study with data collected here at U of M and then also at the Medical University of South Carolina. We were working with a sample of 78 participants, majority of whom were white, majority of whom were male. We had greater diversity with respect to age, so average age of around 52 with a standard deviation of around 12. And this was the silver lining of COVID. I think, and Dr. Meade, you know this better than I do, but we were just about to start data collection like the day before everything shut down in March 2020. So we had to pivot a lot of our data collection, pretty much all of our data collection, to remote video assessments. But as a result of that, we actually got a very diverse sample with respect to geography. So instead of having a really tight catchment area of probably 20 to 30 miles within Ann Arbor, we were able to see folks in their homes, and we actually reached folks in 13 states as part of this study. We collected data that we're presenting here via online survey platform, but we also had an interactive telehealth-like cognitive assessment battery that we were using as part of this project too. And the healthcare engagement piece, which is really core to this project, we use the patient activation measure to get at that. So I want to be mindful of time. Here's an overview of our instruments, our measures. The grit scale was something that we used to really get at this attitudinal piece. So perseverance, we sometimes refer to this as mastery motivation. But you can see some of the items on here talking about overcoming setbacks, being able to bounce back from challenges and pitfalls, different things like that. And then this is the patient activation measure. So there's a really interesting scoring algorithm, but the actual instrument itself is pretty straightforward. Respondents are asked to rate how strongly they agree or disagree with different statements related to healthcare engagement. So this is an overview of how the data from the PAM actually manifest. So when we look at the PAM, the data from the PAM, we can classify individuals as belonging to one of four groups. And this is really helpful, again, from that clinician perspective, because having an understanding of where someone is on a spectrum of healthcare engagement actually gives us some ideas in terms of maybe goals that would be useful to improve engagement or to enhance engagement. And you can see that the sort of lowest level of engagement they describe as feeling overwhelmed and disengaged, with the most engaged level being someone who's maintaining changes, adapting when health or life situation requires it. So being very flexible, that flexibility piece. So again, we used our PAN data to classify folks as belonging to these four groups. Majority of folks belong to that most engaged group. This was a convenient sample, I'll add, so it probably isn't that surprising that the folks who are really eager to participate in research are also pretty adept at managing their own healthcare. But we did see a number of folks, just under half of our sample, around a third of our sample was in that third group. So taking action and gaining control, doing pretty well, but still room for improvement or room for increased engagement. And then a number of folks were in that second group, so becoming aware, but still struggling with feeling independent with respect to healthcare engagement and self-management. And then about 5 participants in our sample fell in that least engaged group of being pretty disengaged and pretty overwhelmed. Now, because of how the difference in cell size here, we actually combined those first and second groups, or third and fourth groups, with these bullets. So we had a PAM group C prime, is how we referred to it. So we had 16 participants that were either kind of in that becoming aware, still struggling, or pretty overwhelmed and pretty disengaged. So we combined those 16 folks into a single group. We used ANOVA and chi-square to look for significant differences. And I'm gonna, this is a lot right here, but so what I have here is basically just an overview of significant differences that we found between groups, accompanied by an effect size indicator. So I'll walk through this pretty quickly. These are differences where we saw the largest, these were the largest differences that we detected. And I'll talk more about sort of the directionality and where these differences hang, but differences in education, differences in stress, differences in that concept of grit or perseverance, differences in income, secondary conditions, subjective mental health ratings or self-reported mental health, subjective social functioning, again, self-reported social functioning, and cognitive functioning as well. And this last point, again, self-reported, we're not looking at the data we collected as part of those interactive cognitive assessments. And then these were differences that were a little bit smaller, but still significant. Both depression and anxiety, disability ratings, subjective physical health, and then employment. And that last one, employment, that was a chi-square that we used. We did not detect significant differences between other criteria, including other demographic factors, injury characteristics, and other emotional, attitudinal, and health outcomes. And this is what I was talking about, where we can actually visualize those differences a little bit more. So these were how we described them. PAM group A is that most engaged group. PAM group B is this sort of middle of the road group, doing a lot of things in service of their health and their independence with respect to self-management, but still with some pretty significant room to grow. And then PAM group C prime, that group that was, you know, disengaged, overwhelmed, and otherwise struggling with healthcare engagement. So the cells are the cells that are shaded green. These are areas where folks were doing generally better. Folks that are shaded, or cells that are shaded orange, are cells where folks were either doing were not doing quite so well, or where things were, so for example, with education, lower levels of education. And then this cell right here, this is actually just demonstrating a pretty linear association where PAM group A had less stress than PAM group B, and PAM group B had less stress than PAM group C. So a pretty linear association right here. I'm mindful of the time, so I'm going to move through this one without diving too into the weeds on it. These are variables that we did not detect significant differences. So these, each of these groups was relatively equivalent. I don't want to overstep, but we at least didn't see significant differences with respect to some of these demographic factors, some of these injury characteristics, and then other data that we obtained from the chart. So in thinking about what this means, people living with traumatic spinal cord injury differ across a wide range of salient variables contingent on healthcare engagement. And importantly, modifiable factors seem to more strongly correspond with healthcare engagement than fixed factors. I think that's important. Again, as a psychologist, it's really sort of my job to work with patients on engaging in behavior change. So having some data to actually look to and saying that these are things we can work on in clinic, that's very important. Now, these data are obviously limited. This was a cross-sectional study, so we can't really get into the weeds on cause and effect. So I'm going to just go back for a second to kind of make that point. We can talk about how folks who are, you know, less depressed and less anxious are more likely to be engaged in their healthcare, but it could very well be the opposite, or at least a little bit of both, where maybe being more engaged in your healthcare actually yields a protective effect for depression and anxiety. Because these data are cross-sectional and we really can't look at the temporal, sort of the time relationship between some of these factors, we can't speak too specifically about that cause and effect. Or some other variable that might be correlating with these factors. We had relatively limited diversity in terms of sample characteristics, but like I mentioned, this was a convenience sample. We really were just trying to develop some proof of concept with this, and this lays a really strong foundation for future projects that are designed on getting a little bit more specific and a little bit more nuanced with some of this work. And again, getting to that point that I was just making, I think there's a real need for more longitudinal research. So really giving us the foundation to talk more about cause and effect as opposed to correlation. I think that it would be useful to potentially consider looking at the efficacy of specific interventions designed on increasing healthcare engagement in the years after spinal cord injury. I think we have enough data with respect to the larger literature to really support that as being a theoretically grounded hypothesis. And I think it would be really interesting to do more qualitative research, or really to look at, similar to that 2004 paper I cited in the introduction, really looking at the experiences of people with spinal cord injury with respect to healthcare engagement. What are barriers that they're identifying, and what are maybe facilitators that they're identifying that a more quantitative approach really isn't going to allow us to stumble upon. And thank you. Yeah, I'm a little bit over on time, but I'm glad that I was able to kind of hit the highlights of those areas. And I'd like to thank the Nielsen Foundation for funding this project, and for Dr. Meade's leadership on this study and allowing me to share these data with you all today. So I don't know what our situation is for questions, but I'm happy also to answer questions after today's meeting over email, or however folks want to get in touch.
Hi, everyone. My name is Sunki Westlake. I'm a rehab engineer here at Michigan Medicine. This is Michael Blackstock. You are?
I'm Mike Blackstock. I'm an occupational therapist at Michigan Medicine.
So we're here to present on IMPART, which stands for Improving Access to Rehabilitation Technologies. We're a multidiscipline team here on the inpatient side. We'll start with a video of our program. So what's our program? It stands for Improving Access to Rehabilitation Technology. We are a grant-funded program. We're funded by the Nielsen Foundation. Thank goodness for it, Nielsen, because it's like Nielsen and Michigan Medicine is like interchangeable. So it's a 2-year grant. It combines the best aspects of just the gaming world and the community that comes around, that comes with the gaming world, and adapt them and use them for to benefit the demographic, that's the individuals with spinal cord injury. And we are a multidisciplinary team. We've got representation from recreational therapy, rehab engineering, occupational therapy, and our physiatrists, and all of our PM&R departments. I feel like it's got a really good representation. And as a rehabilitation engineer, when I see my patients, I'm thinking about like adaptations and how to make activities accessible. And gaming for the longest time hasn't been very accessible until the creation of devices like the Xbox adaptive controller, which you see in the photo on the lap of the gamer, right in the center here, the white and black device, that's an Xbox adaptive controller. So because of devices like that, it allows a clinician and an engineer like myself be able to make gaming accessible for individuals with disabilities. And then also on the therapeutic side, it allows for gaming to be used as a therapeutic method to reach therapeutic goals. And just the nature of gaming is that gaming is enticing, it's engaging, it's addictive, and that's such a really good motivational tool. So for me on my day-to-day, especially over on the Mott side, the kids, you might be able to reason with an adult and say, hey, this is really going to be really good for your rehab. Let's play these, do these activities, and it's going to be good for you. But over at Mott, for the kids, they don't care. If it's not fun, if it's not engaging, they're not going to want to do these activities. So to incorporate gaming and work with occupational therapists or PTs, for me, so when I do my coach treats, it's either I'm working with the therapists to make their therapeutic goals easier and more engaging to reach, and kind of hide therapeutic goals within the games. Or I'm seeing the patients by myself and working on how to make these games as easy as possible for them to play, regardless of their functional level. I feel like the advisory board is like really the gem that we didn't expect how robust our advisory board would be. We intentionally picked out advisory board members to incorporate like our partners in other medical facilities, and then out in the industry, as well as individuals that have spinal cord injuries and game, and the individuals that have spinal cord injuries that may not game. But honestly, like, our advisory board is amazing. We've got we have several past patients, and one is a phenomenal, what is he, electrical engineering? Jim is electrical, he programs, and he's already like thought of ideas for us to create new adaptive controllers. Corey, I gotta fill you in on that. It's awesome. And then our other advisory board member, Matt, he's actually pictured right here with the back, both of them have backwards hat on, but the gray backwards hat. He created the video for us that you just watched. He was not a gamer before, but got into gaming after the injury, and both of those patients did rehab with us. And after the fact, Matt decided, hey, let's try gaming, and he was already getting into gaming and streaming, and we had asked him if he'd like to be an advisory board member. So he joined, and he's really into social media, so he made that video voluntarily, and then was like, hey, would you like to use it for anything? And so that's been really great, and I feel like that group keeps us grounded, but also like really makes our program grow in intentional, effective ways. So our grant as a whole, we have several pillars. The big thing is that our goal is to host rehab arcades every other month. And so far we have one coming up this Thursday, and that'll be our 4th event. And we have different themes each arcade event, but basically we invite our adaptive gamers, and part of that is that as you're coming into the arcade, we're going to have clinicians evaluating you to be able to game. And it's a collaborative gaming community. And this week's session, Thursday, we're going to try to game with individuals elsewhere, so they're going to be virtually joining in. We started streaming on Facebook so that people can watch what we're doing, and we're getting a little more attention on social media, and gaming organizations like Able Gamers or Microsoft, they're seeing what we're doing, and they're really starting to get really impressed with these events that we're hosting. Part of our grant is to come up with an evaluation lab, and that really means that it's just a robust inventory of equipment that clinicians and engineers like myself can utilize to evaluate our patients. And part of the Rehab Arcade, we've set aside budget dollars to equip what we're calling a group of super users. Over the course of the 2 years, we have budget enough to equip maybe from 5 to 10 super users, and basically they're going to get one-on-one evaluation by a technology professional. So myself or Courtney, who also has an assistive technology professional certification, evaluation for what will work for you, and then funding for that equipment. Adaptive gaming equipment can be really expensive. Gaming alone, if you're just a standard player, you're just going to need a console, and oftentimes the console comes with a controller, so it's kind of all in one package, couple $100. But traditionally, until Xbox came out with their adaptive controller, a traditional adaptive gaming controller could cost you anywhere from like $1,000 to $2,000, just the controller itself. Then on top of that, the gaming console and all that other stuff. And then if you're using a sip and puff versus buttons, each of them, if you're getting it from a specialty vendor, those round jelly bean buttons could cost you like $70 each. So it gets expensive really quickly. And so part of our grant, we were intentional about setting aside funding specifically to equip our gamers with the whole suite of equipment they'll need to be able to game with adaptations. And then some of our outcome products that are built into the grant goals is to come up with open source education content. So that would be like videos and social media posts, articles, and any of those things that could be available to the public. And as we're learning more things, we're going to be talking about how to use certain adapters, or how do we creatively use mounts so that we can mount devices to be accessible for our participants. We are working with a VR software company, and Mike will go over that in just a little bit. We're going to create a new software, working with them as our contractor to come up with a tool that'll help our therapists be able to track the gaming and how the participant or the patient is using the gaming, and grade the difficulty, things like that. And then finally, this is going to be Corey's homework to come up with a referral guideline. So video gaming is new, especially in the rehab world. Using video games, what we've seen kind of historically is that even myself, I say like, I'm not a gamer, but I like play the game just enough to know how to hack it and make it accessible. Like which buttons are needed, which controller are needed. Okay, the X, Y, and then the joystick, cool. Just that enough to be able to know, okay, so what adaptations do I need to make? By no means do I go home and like choose to play video games, because that's like my activity. I exercise, and my husband tells me that's not a hobby. Like, if you could give me all day, I would just work out. And he's like, that's not a hobby. I'm like, whatever. So so I can understand how it could be kind of overwhelming, and like if you don't play video games, to feel like, oh well, I'm kind of I'm an intruder, you know, it's the imposter syndrome of utilizing games within the therapy session could be kind of daunting. And so also it might be hard to figure out, oh, which patient would be appropriate to utilize gaming as part of a therapeutic session. So our other goal within the grant cycle is to come up with a referral guideline, just to kind of walk our clinicians through who may benefit from using adaptive gaming or using VR as part of their therapeutic sessions.
I'm still Mike. I'm another part of the Impart, and there are a lot of benefits to gaming, whether, you know, regardless of your health history, spinal cord injury or not, but someone with a spinal cord injury can have a whole bunch more benefits than somebody without a spinal cord injury. Because as we know as clinicians, if you have somebody with a spinal cord injury, they have a major disruption to their roles, routines, self-esteem, the way they view themselves, their social opportunities. And so this could be an alternative way that they can have that outlet. They can be able to, we have on the screen a list of a bunch of different benefits, but you know, we know that we could probably come up with a bunch more benefits even than the ones that are on the screen. I grew up at a time when video games were not as social, because I grew up before video games were like online, right? I was playing Mario Kart on Nintendo 64 with whoever happened to be in the room, probably against a computer. But now, you know, you can socialize with anybody around the world that you want to. You don't have to go to an arcade to be with another person. So physically, you don't need to get around to have that social outlet. Monetarily, apparently, there's a big thing with gaming where you can. I don't totally understand it, but people like to watch other people play video games instead of playing themselves. So there's money to be made there if you stream yourself on social media. I know people make money that way. Competition, if you are somebody maybe that was very into sports or athletics or something like that, and you like that competition, but physically you're not able to necessarily compete physically, or maybe in the wintertime when the UMA's basketball isn't going on, you could find something to do and still get that competition out of video gaming with other people. It could be from a physical standpoint, strength, range of motion, all those things that people are looking to gain back after a spinal cord injury. It can be as therapeutic or not therapeutic as you would like it to be. A lot of people use gaming to get away from, as an escape. So they might not necessarily want it to be therapeutic. Other people might want to get that therapeutic aspect where they might want to strengthen muscles that are weaker, or they might want to work on range of motion. This would be an opportunity to do either of those things based on the way that we set up the adaptations, and that'll be on the next screen where we talk about the different adaptations. These are on the screen. You see a whole bunch of different adaptations that people have used. These are all pictures from some of our rehab arcade events. There's a lot of variables to consider when we're trying to set somebody up to participate in gaming in an adaptive way. Some of the things that we have to think about are what game are they playing, and then what are the controls like in this game prior to adaptation. So how does the person, do they have to move around, or can they be stable? How do they interact with their environment? How do they interact with items? Is the person who is playing the game, have they played this game before? Do they know how to play the game? Because if they don't know how to, sometimes if they don't know how to play the game, it's easier because they don't have a preset in their mind how they have to play the game. And then we can just start with a fresh, clean slate, because one of the ways that we can adapt it is by maybe taking away some of the controls that aren't necessarily needed. A first person shooter has 17 different controls, but really all you need to walk around is you walk around and pull a trigger at the basics. And maybe they don't need, all the other controls, or maybe we can combine some other controls. So we're thinking, those are things that we're thinking about in the back of our head. The arcades are kind of organized chaos, because we're trying to set up many people with, obviously, you can see in the pictures many different setups. I don't think there's been a single setup that has been the same from one person to the next, unless that's another good thing about the arcade, though, is that it gives opportunities for people who are more experienced. Maybe they've been gaming and using one set of equipment, but they want to see somebody else's setup, and they want to try something else, and maybe that would work better for them, or maybe they just want to see what else is out there, what other equipment is out there. So that's one thing that's been nice about the arcade. But we're trying to set up everyone's different adaptations at the same time, and that's where the lab really come, or the what's it called? Evaluation lab. Yeah, the evaluation lab comes in, where it's really a one-on-one with the clinician, and they can do that setup and see what exactly people need. This next one is a video that should, I think, play. Maybe. Is it playing? I think it's playing. So this is the current state of that virtual reality software that we're creating in partnership with MXT Reality. That they sent us this video. I believe at the end of the week we might be getting a beta version to actually test it out. So what's happening is, on the top right side is what the person would see in the virtual reality goggles. That's what they would see as they're playing the game. Just looks like normal, what they would see without this program running. Down at the bottom right, and then on the left side, is really what the program is doing. That's what, on the bottom right, is what the program is seeing. That's the head and the two hand controllers. It's tracking their position, their movement, their orientation. It's and then it's tracking that data on the left side. I think the video's over. It's just a 1.5-minute video. So there's nothing really actually loading. But on the left side is all the data that's being compiled, because in a virtual reality game, it's tracking it all the time regardless. It's just never output anywhere that you could actually use. Whether you're maybe using a virtual reality as a clinician for therapy, or maybe somebody, every time I work with somebody who has used virtual reality for therapy, I don't think I've been in one session where somebody hasn't said, oh, we got to get one of these for home. This is going to be the new workout for home, whatever. So everybody wants to use it as a home exercise program. And so the idea of this program that we're creating is that it's going to be a free software that anybody can use in the background of any game that they're playing. So they can track their progress by, points in the game, or what the software is for is it's going to track how many repetitions of a movement did you do, how far was what was the range of motion, what was the speed that the controllers were moving at. So all of these things are physical markers of progress that then could be tracked either by a clinician in therapy or through a person trying to do it on their own for a home exercise program. These obviously are people that would want to use gaming for more of the strengthening aspect. Otherwise, we would probably go back to like the desk laptop setups with the buttons and joysticks if they were looking for a less physical outlet for gaming. That's it for the presentations. Anybody got any questions?
We have a question here online. Is this something we're able to refer our patients to? If so, what is the best way to do that?
Yes.
So we have a questionnaire for individuals that might be interested in coming to just the arcade, or I think we have an email specific to our program, but I think if I can send both of that information to everyone whoever is organizing the symposium, we can get that information out to you guys. Yeah. So if it's an individual, you can send a link to the questionnaire out, and it kind of gives us an information who you are and if you want to game with us. Oh yeah, and then there's a flyer too. We'll send that out to all of our events, as well as a general flyer of our program. We have those, so we'll send that out to the group through whatever authorized person.
Is this open to only inpatients, outpatients, both nationally and other?
Can you repeat the question for those of us in the webinar?
The question was, is it open to just inpatient? Who is it open to locally, nationally? It's open to generally everyone. It is grant funded by the Nielsen Foundation. So we're going to be serving our SCI population. However, if a participant brings their friend into the arcade and wants to game with them, we're going to be setting their adaptations up. But all of the super user funds would be going to somebody with an SCI. But we also started making partnerships with organizations such as Able Gamers, and they have there's some funding opportunities for individuals. So we'll take information from anybody across everywhere the world if they want to jump on the other side of the world and want to jump onto our gaming days. We are trying to find ways, like for example, this week we're playing Rocket League, and Rocket League is open to anyone with the passcode, and we'll provide that passcode to get into our match. During that time, we invited people from kind of across the nation. We have some partners over at Mott. They're presenting at TwitchCon this week, and we invited them to come game with us with whoever's at their conference.
Thursday's event is kind of our first trial at remote participation of doing it not actually in the room.
Okay.
Thank you all very much. I was presenting today to give you an overview on the University of Michigan Center for Disability Health and Wellness. I am very fortunate to be able to be working on this with Dr. Michael McKee, who you'll hear from later, as well as India Foy, who's our new manager. We're running a little bit behind, but if anyone wants to go to our website, you can go to disability medicine or disabilityhealth.medicine.umich.edu, and we have a video about why we're doing the Center for Disability Health and Wellness and kind of some of the key activities. So the overall mission of the center is to develop and apply innovative research, clinical, and educational strategies to address health inequities or inequities in healthcare access, quality, and outcomes experienced by individuals with physical, sensory, and developmental disabilities across the lifespan. The vision is one of working in partnership with the disability community to ensure that all folks have equal access. I think the key thing here is that healthcare disparities we know exist for individuals with disabilities, and they're especially prevalent for individuals from marginalized communities, that we have a responsibility, at least I do feel, not just to conduct research that keeps identifying the problems and the disparities, but to actually take action to try and change and transform healthcare to make a difference, to be more engaging. I know I've always felt this way in terms of, we could see this in terms of the commitment of the clinical care, in terms of the extra steps and the extra programs that you do that go above and beyond. And I guess the center is a way of really trying to operationalize and build on those type of energies and collaborations. The center really began under different names. Previously, it was the Collaboratory for Technology, Health, and Independence. And this was when we had the TikTok, the Rehab Engineering Research Center. And then it went to the Collaboratory for Disability Health. And then we got approved by the health system because you need, in order to use the title center, you need to get the official approval. And we got that in the fall of 2019. And then we received office additional funds and support from the medical school. We have physical office space down in the lower level of Burlington, Suite 6. And this is, I think, a benefit for folks who want to collaborate in the future. So the four components are really the research, education, and training, clinical components, and community outreach. We once again conduct activities. We have 3 primary center grants that we're working with now, as well as associated clinical or associated research activities, and always a lot under review or in being planned. The first one of these, most relevant to this group, is the Michigan Spinal Cord Injury Model Systems. This is a collaboration with Mary Free Bed Rehabilitation Hospital and funded by National Institute of Disability Rehabilitation, Disability Independent Living and Rehabilitation Research in the Administration on Community Living. The focus here is once again of thinking about improving the health of all individuals living within spinal cord injury by enhancing access, really thinking about conducting the needing activities and engaging individuals with spinal cord injury. The primary, the focus is once again comprehensive care, improving access. And the pieces here are the national database, in which we have Rachel and Madeline over here, who are enrolling and consenting our folks with spinal cord injury on the inpatient unit, and then following up with them at 1 year, 5 years, 10 years, 20 years. These individuals are then entered into the National Spinal Cord Injury Model Systems database. This is the largest research and database effort in the world related to disability. It started in the 1970s and has over 50,000 unique individuals with spinal cord injury participating. It probably provides that information and data for about half the studies on spinal cord injury that go on in the United States. It's a really rich database and an important source of research that is going on. We're also doing a site-specific project here that is creating a hospitalization risk index to identify what are the factors that predict hospitalization, especially for folks with more chronic spinal cord injury. We know kind of what happens in the first few years, but we hope that if we can get a risk index, that we can get insurance companies to be more willing to be able to support the type of intervention services, case management to prevent that hospitalization. And Dr. Mark Peterson is leading that effort. We participate in collaborative research projects with the other 17 model systems. Our current ones include those associated with assistive technology and the equitable access to wheelchairs and such, related to oral health, aging, autonomic functioning, and social networks. I think there may be one or two others in there, and those can either be longitudinal or cross-sectional. And finally, we do knowledge translation activities both here at the University of Michigan and in collaboration with the Knowledge Translation Center. The investigating disability factors and promoting environmental access for healthy living, or IDEAL RRTC, is focused on promoting healthy aging for individuals with long-term physical disabilities. We received this grant center grant in 2018, and we are going to be extending it a year until 2024. It really looks at the intersection between individual and environmental factors, really looking at the context of the environment and how in the aging process and outcomes. We have this, as well as many of the projects in the system, are based on an expanded model of the ICF that recognizes the role of the healthcare environment in healthcare disparities. And so really thinks about using that center box, the access to healthcare, as potentially modifiable factors that we can target for interventions and system levels programming. That grant has 5 projects related to using the national database, a community inquiry, looking at the environmental supports, looking at doing model clinics for folks with disability access that Dr. McKee is currently finishing up with, and then looking at transportation access. Many of that research is already completed and on our website. We recently got a 3rd center grant called the AHEAD DC, focused on advancing or identifying and addressing healthcare disparities among adults with physical, cognitive, sensory, and developmental disabilities from marginalized and diverse communities. Once again, we're partnering with individuals with disabilities and the disability communities, as well as collaborators from Augusta University and University of Central Florida on knowledge translation training activities, as well as 5 research projects. These are looking at developing a disability dashboard to use public health data to look in more depth about intersectionality, to examine the social determinants of health and how that impact healthcare utilization for adults with IDD, to examine HIV prevention and prevention sites for individuals with disabilities, to have primary care clinics that provide a disability navigator for healthcare access, and a pharmacy review project, and to create a disability health index, which will rate or rank healthcare systems for the extent that they provide or are accessible and provide quality care for individuals with disability. CDHW also conducts training and educational activities. We have regular webinars and Facebook Live events. We have an SCI e-learning course that is available over the learning no, not mLearning, but one of the platforms. We have interdisciplinary seminars, we have monthly training seminars, and we have capacity building that we're going to be starting in the community. We're also going to be starting simulated patients in which we're going to be training individuals with disabilities to provide the hands-on patient experience to new healthcare providers and medical students. Our clinical activities are once again focused on enhancing clinical care. Many of these are created through once again, the advocacy and what we do to help improve healthcare outcomes. The disability field we'll talk about in a little bit, but there are specific model clinics that are out there. We have best practice alerts that are currently part of a research project, but will eventually be integrated more fully into the medical care. And then we have clinical tips and guidelines for working with individuals with disabilities. We have an accessibility task force that now meets once a month to identify and try to influence policies, to create resources, and to develop protocols. During COVID, we created guidelines for working with individuals with disabilities for the health system's general approach to allowing individuals with disabilities to have family members in the room, and to ensure that there wasn't an evaluation of quality of life based on disability status, and then work to really enhance the accessibility of COVID vaccination and screening clinics. We do a lot of community outreach and advocacy. We have a new community advisory board, many of that focused on organizations from Flint and Detroit and marginalized and underserved communities. But once again, really trying to make sure that the research we do, our activities, are grounded in what's needed and of interest to the folks out there. We hope to do more policy briefs as well as community health fairs in the future. We do have once again, the regular webinar series. We have the annual Disability Research Day and a monthly annual MLK panel. We have a website, a Twitter account, and a social media Facebook group that we use to get information out there. We also have a quarterly newsletter that we send out via email. There are many opportunities in terms of future collaborations for partnerships, and just to use the space. Just one word about the disability field, because this is really important. What you see in the medical record is the work and the effort of this group, and supported by one of the grants Dr. McKee was able to pull in. So we have the involvement of EPIC to create a field in the medical record that allows individuals with disabilities to self-identify with the type of accommodation they require. This information can then be used to help plan outpatient clinic visits and hopefully really improve access to quality care. You may want to think when you're having patients leave to update their disability tabs so their healthcare providers know they need a wheelchair, know they have a ventilator, know what they may be coming in and dealing with, so that more appropriate types of supports are able to be provided. So once again, check about the disability tab prior to the appointment, secure the items. If you can, talk with the patient, see if sometimes there are things you can do and things you can't, but problem solving with them beforehand is recommended. And then once again, share information with the team. We do have protocols and tip sheets on the website. We would love more involvement to say, okay, what are the best practices that you have developed for working with folks with spinal cord injury to make sure that they get quality care, and to continue to have, positive outcomes. So once again, we're an interdisciplinary center. We welcome membership from faculty members, from staff across the centers. Is primarily focused in Here at U of M, although we have some, definitely our community partners, we have a regular community advisory board, and we're committed to working in partnership with various groups. Just a couple of things in terms of the benefits and places. We have the social media. So if you have information you want to get out there, please let us know, whether it's accessibility events. Let's not reinvent the wheel. We also have space. Once again, if you need outpatient space, we do have that either to store equipment or to use. We have that lower level suite in in Burlington, where you can keep stuff, where you can get mail, where we can figure out how to better support you for the good of our patients. I think that's it for now. I know we're running behind, but please contact me later if you have any questions. My colleague, Dr. Michael McKee, is going to be talking next on continuous glucose monitoring and diabetes management.
Hello, everybody. I'm going to back up so everyone can see me on the screen. It's great to be here. Thank you for inviting me. So I'm going to be starting off, and I'll have my partner, Emma, go ahead to present the rest of the slides, and I'll wrap up at the end. So we're going to be talking about the project utilization and feasibility of continuous glucose monitoring to facilitate self-management skills among adults with a spinal cord injury. So. Want to acknowledge our team that we have here. So we have myself, Emma Butcher, and also Dr. Gianna Rodriguez, Dr. James Akins, Dr. Mark Peterson, Dr. Michelle Meade, and Dr. Caroline Richardson as part of this project. We don't have any financial disclosures, and we also want to recognize that we did receive funding through the Craig Nielsen Foundation grant, so we appreciate their support. So I want to just briefly take a step back and talk about how this idea came to fruition. I had a patient, the name has been changed to protect the identity. So Joe is an individual who has a spinal cord disorder. Initially started off with prediabetes and struggled in terms of managing prediabetes due to loss of physical activity, has a upper extremity dexterity and motility loss. And as things progressed, prediabetes became diabetes. Despite going into diabetes, we struggled to get finger sticks because of the dexterity issues. And even though I could get other patients to have a continuous glucose monitoring equipment, I could not get it approved for Joe. And so as a result, I multiple appeals, and we just could not get it because they felt it was not really suitable for this individual, which kind of shocked me that this would have been a perfect solution to be able to manage and allow the individual to better self-manage diabetes through the use of a continuous glucose monitoring. So we're now wanting to go ahead do a test to see if this is a feasible solution to manage people with prediabetes and ultimately diabetes.
So for a little bit of background on this research study, adults with spinal cord injury are at risk for negative health outcomes, which can impact participation, employment, and quality of life. Adults in this population also have cardiometabolic conditions, especially diabetes, that can have significant downstream consequences, which include increased healthcare costs, pressure sores, amputation, sepsis, and mortality. Also, adult patients with SCI have a risk of diabetes that is 66% higher than the general population. So traditionally, diabetes and prediabetes management options have been limited to options such as a finger stick. And after hearing Joe's story, we can now know that that can be very inaccessible for individuals with SCI. However, there are newer technologies that offer an intersection of solutions to help with accessibility and self-management, processes, and behaviors. One of which are continuous glucose monitoring. So, and with CGM, patients can receive real-time information about any impacts of their health choices. And also CGM can influence patients' psychological and physical health outcomes. So the purpose of this pilot study was to determine the feasibility and usability of continuous glucose monitoring by adults with spinal cord injury, as well as evaluate the impact of CGM use on self-management processes and behaviors. So there were a few other aims involved in this study, such as assess CGM usability and feasibility in a diverse sample of adults, determine the association between CGM use and self-management processes and behaviors, as well as determine the impact of CGM use on psychosocial and physiological outcomes, all among patients who are pre-diabetic adults with SCI. So this study used two types of continuous glucose monitors, which are up on the screen here. We used the Abbott Libre and the Dexcom G6. And in a prior study with a collaborator, Dr. Richardson, it showed that there was an improvement in A1C and with weight reduction. And this study provided a basis for our study by using CGM for pre-diabetic adults with SCI. So this was a mixed method study as well as a single-armed feasibility and usability study of continuous glucose monitoring by adults with spinal cord injury. This study had 11 enrolled participants, 9 of which were male and 2 of which were female, and you can see the breakdown of the study status of our participants here. And this study had 3 different phases for it. The first phase was called the usability and feasibility testing portion of the study, where all of the participants began with a baseline assessment, a process evaluation, and then they all got training on continuous glucose monitoring. And then there was a section for 2 weeks that the patients were having CGM scanning, but that was monitored by the research staff. And the feedback wasn't given yet to the participants, and then the participants did daily diaries. And as I said before, this phase lasted for 2 weeks. Then the second phase of the study was the CGM self-monitoring intervention part of it. So that it started off with a process evaluation again, and then there was self-monitoring training from the research staff onto the participants about how to use a CGM. And then the participants had CGM usage and daily diaries for 6 weeks. And throughout that 6 weeks, there were 3 assessments. And finally, there was the third phase, which is the follow-up assessments portion of the research study, which again started off with a process evaluation. And right after the usage of the CGMs, the participants underwent a post-intervention assessment, and then they had a final post-intervention assessment again at the 6-month mark after their baseline assessment.
So I wanted to just kind of give a little bit about the characteristics of our participants. So we had 11 individuals who were enrolled. Some of them, unfortunately, had to be removed or pass away or had to drop out. But of the 11 individuals, they were mostly male, which is not uncommon for spinal cord injuries or disorders to have a predominance for male gender. The race was actually pretty split, and for ethnicity, we were not successful in having anybody from a Latinx to be part of our study. For the SCI level, we had 6 individuals who have paraplegia and 5 with quadriplegia. We do have more details if needed. Education, most of them were highly educated. Most of them were 4-year college or higher. Some of them actually had master's degrees. And then in terms of the A1C upon enrollment, was a 6.0, and health literacy, most had adequate health literacy. So 4 of the individuals had to be removed from the study for this analysis. 1 passed away, unfortunately, and 1 was behavioral, and 2 were more study deviations, protocol deviations. But what we found among the 7 that were involved in the study, we had a mean score, a mean A1C that went from 6.0 and it actually dropped down to 5.73. So it was not a trivial drop, but given the smaller sample, that was not statistically significant. The overall trend was positive with improved A1C control, and additionally, 3 out of the 7 were able to go back to a normal range instead of a pre-diabetic range. So that was promising. We had a lot of difficulties in terms of coordination. We also had some staff turnover and availability issues that did complicate it, but we do have interviews and some findings from 5 individuals, more on the qualitative and additional assessments, sort of a wrap up for the project. There was high satisfaction with the intervention. Most of them actually liked the idea of the CGM. There was a tech appeal, but many of them actually preferred to have the freestyle Libre, which to me was a little bit of a surprise because it requires some more hand-holding for scanning versus Dexcom, which is actually can be more app-based. Freestyle was now available in app, but early on it was not available. The other thing is for the beginning of the study, we provided an overview on low-carb diet, and many of them actually felt that was a helpful part of the study, and many of them continued to commit to that kind of diet as well. And then the other thing we learned along the way was also sensor placement and also adherence difficulties. Many of them had hyperhidrosis, excessive sweating, and so sensors repeatedly fell off. And so this was a big struggle for us. And it did jeopardize a lot of our sensor-based data. And so there was a lot, especially in the latter stages, where we were trying to troubleshoot tegaderms, wraps with mixed results. So we have some data in terms of lessons learned and also strategies to be able to improve sensor placement and adherence. And then the other one, in terms of the diet, many of them actually said that they are committed to maintaining the diet post-intervention. So there seems to be some commitment to following that diet, after the study. So the continuous glucose monitoring does show promise, but again, there were a lot of things that we still need to figure out, especially the sensor placement, adherence, and what are some better protocols to make sure that they can benefit from this technology. So additional work needs to be done for it. The other thing is there were a lot of coordination, transportation struggles. We also learned some things like food diary was very difficult, challenging to collect, whether we can move to more like a photo based type of diary. And then the other one I mentioned that the freestyle app, it was preferred because it has a reader. Both of them have readers, but the reader we had available was through the Abbott Freestyle. And many of them prefer to have it rather than trying to set up an app in their phones. Most of them have phones, but many of them prefer not to bother, try to download. So there seems to be some digital literacy issues as well. So if that is going to be something in the future to be implemented, tech support, further reminders are going to be critical. So having more of a virtual tech support and also having more streamlined ways to get the sensor data is going to be critical for this population. So we unfortunately had a small sample. We were shooting for 10 to 15. So ultimate sample was 7. So we have a small sample. There was some timeline deviations. Some of them were internal from SAP issues. And again, the sensor data issues, many of them falling off repeatedly. And then next steps, we're still wrapping up. We have a few individuals that we're going to be doing the follow-up wrap-up interviews. So we have more to learn. But the key thing is finding out food log alternatives, whether like photos, and we also need to have a protocol for sensor adhesion and also placement to make sure we get that set. So I'm gonna turn over. Any questions?
Thank you. Can you say a little bit about what percentage of individuals with spinal cord injury have diabetes and what some of the consequences of diabetes are?
Yeah, thank you for the question. So in terms of the actual prevalence of diabetes, I don't remember at the top of my head, but the risk, as Emma mentioned, 66% higher risk of diabetes compared to their individuals or their peers without a spinal cord injury. So I mean, roughly right now, we're in the teens for diabetes for the general population, and about 25+% for pre-diabetes. So I would expect that there's probably something even higher than that.
Sorry, again, it's also, I think, a recent paper showed, an analysis showed that, you know, I think we think about managing a spinal cord injury and how hard and life-changing that is. And I think I went into this really minimizing what it takes to manage the diabetes because of that difference. However, we know that folks with spinal cord injury and diabetes have a much higher rate of sepsis and other serious life-threatening conditions than those without. And so it's really worth thinking about and preparing folks at risk to say, how are you going to continue to manage your health given the spinal cord injury? I know this is a little more, it's going to be more difficult, but it's important in order to keep quality of life, in order to keep out of the hospital, in order to stop pressure sores, to stop DVTs, to stop sepsis, to stop stroke, that you're going to need to pay attention to and monitor your blood sugar in the future.
Thank you. So one other thing, and this is really anecdotal. So we use data direct to be able to find many of these individuals. And many of them did not have A1C, which was a big surprise. So it's one thing that I would encourage all of us, and this is primary care, also physical medicine rehabilitation, to consider adding an A1C so we can make sure we capture those who have pre-diabetes, diabetes, and obviously that's separate from, per se, from a study enrollment or eligibility, but that was one thing that we did notice. We need to encourage more on that. So, thank you. Are there any questions online? Okay, thank you.
So my name is Jane Huggins, and I am going to talk to you about brain-computer interfaces for people with spinal cord injury and try to give you some idea of what realistic expectations are in a realistic timeline. I have to do disclosures because everything I do is brain-computer interfaces. So I am co-editor-in-chief of the journal Brain-Computer Interfaces. And I do have a patent on one aspect of brain-computer interfaces, and I've got all sorts of different grant funding for, well, brain-computer interfaces. You may notice a theme. Brain-computer interfaces is a field with too many names. It can be brain-computer interfaces, brain-machine interfaces, and so on. And yes, it is intentionally halfway cut off in the bottom of the screen because the list just keeps going. And the media has a wonderful ability to rediscover brain-computer interfaces about every other month. And they're always saying, this is a brand new, wonderful thing that no one has ever thought of before. And well, you know, we've been working on brain-computer interfaces since this paper is the 1988 paper. There was a 1986 paper. There was a it's either 69 or 71 reference to brain-computer interfaces. So people have been working on this for a long time. We have been making some progress, but you know, whenever you start seeing the dates and the time, it's not developing quite as fast as they might want you to think, and it's not coming out of nowhere. It's also not going this far. You know, assistive technology or cyborg technology, what are we actually talking about? There are ethical issues that are important to BCI. In general, assistive technology was at least the original motivation I hesitate to say that it's the primary motivation because there are all sorts of people investigating all sorts of different applications. There are some applications for the general population without any disabilities. I haven't quite seen why people really would want it, but you know, not everybody thinks the same. There are some people who want to see improvements. They want to see us merge with the machine, and I guess resistance is futile. But you know, there are ethical questions about privacy and consent and agency and identity and augmentation and bias and justice and access, and we can have long discussions on these topics. And I did have a long discussion of like a whole weekend where we were talking about brain-computer interface ethics, and we published a couple papers on that, and you can go read about that paper in Nature, which, you know, I find it just cool to be able to say I have a paper in Nature, even though I'm like the 8th author or something on there. And only because most of them are in alphabetical order and H comes fairly early in the alphabet. So in general, what is a brain-computer interface? So when we're talking, you know, in general definition terms, what you're trying to do is to record brain activity in some manner. You're trying to, you know, you use electrodes and amplifiers and you extract features, and then you classify those features. So you try to interpret what the brain is doing. Most of what I do is communication applications. And so you might add word prediction or language models, and you provide some feedback to the person. I don't think it's a brain-computer interface unless it's under the voluntary control of the person. There are people who might argue with me on that, but they're wrong. So there are neuroprosthetics and neuromonitoring and things that don't require the voluntary control. But I think brain-computer interfaces require the person to be voluntarily trying to control something. Now, if we're talking about brain-computer interfaces, you know, instead of that communication, there are other applications. I'm looking mostly at the keyboard and the mouse, but there's some fascinating studies where people are trying to use them to control a robot arm, to drive a wheelchair, to control robotic exoskeletons, functional electrical stimulation, prosthetics. There's some interesting stroke rehab and other actual rehabilitation that goes beyond assistive technology. And those may be more beneficial and appropriate for people with spinal cord injury than the kind of communication applications that I'm working on. But I put the stuff that I'm working on at the end so that, because, you know, that's the part I'm most likely to go on and on and on about. So the first thing is there are a lot of different design decisions. Where are you going to draw your signals from? And there are different levels of recording. You can record the EEG, so from the surface of the scalp. You can record the ECOG, which is where I actually started my work. EEG is electroencephalogram. ECOG is electrocorticogram, and it's under the skull, but generally not penetrating the brain for ECOG. And then you can go to actual intracortical, which is penetrating into the brain. You can also use fMRI, though it's really hard to carry around an fMRI machine. They tend to be room-sized. FNIRS is the attempt to carry around an fMRI machine where they're actually shining infrared light through the skull in order to pick up blood flow changes. So you've got to make some decisions on how you're going to record. And then once you've decided on your input signals, you have to figure out what approach. Are you going to be using event-related potentials or imagined movements, mental imagery? There's lots of different approaches. For myself, my lab has chosen this set of applications, but it's probably not the best for people with spinal cord injury because they will often have other options. One of the things about the kind of BCI that I'm using is that if I can get someone typing at 10 selections a minute, I think they are racing. They're like setting speed records for the BCI use at 10 selections a minute. So that's, 10 keys. So I thought we'd go off kind of my path and talk more about the applications that may be more directly beneficial if you have a spinal cord injury. And these aren't my area of complete expertise, but then I do hang around at a lot of brain-computer interface conferences, and this is really cool work, so I enjoy seeing it. So I will enjoy talking about it. So the first thing is using brain-computer interfaces for prosthetics, robotics, exoskeleton, or functional electrostimulation applications. And this is the area that is actually more often referred to as brain-machine interfaces. Brain-machine interface has one key drawback as the term for this area, because it gets abbreviated BMI. And anytime I try to do a search on BMI, it doesn't come up with brain-machine interface as the most common thing. But this has been the goal of NIH's neuroprosthesis program since 1970. So again, when we're talking about timeline, think about this. I was born in 1969. They've been working on this basically since I was born. And there are different, the primary control scheme has been that they want to interpret the signals from individual cells in the brain that are used to control hand and arm function or whatever limb function. And they want to directly interpret those. And then you have different outputs. So once you've got your control signals, it doesn't really matter what you're connecting it to. In my area, I say, I'm making a keyboard. Whether that keyboard is controlled by head movement or by a mouse or by typing on a physical keys or by a brain-computer interface, that doesn't really matter. It's not, it just acts like a keyboard. So it's the same thing here. We're getting signals on moving an arm. How we then make that arm move is more of an engineering problem, because that movement that's under control is highly similar. But the control can be really difficult without sensation. If you have a neuropathy, you know this, and there's also, with the functional electrical stimulation, some serious physical challenges on muscle fatigue and managing muscles. There's probably a whole nother talk in that as well. But there is work that's being done on these things, and there's different approaches. These are some pictures that I pulled out of out of this presentation down here, where there's an exoskeleton, and that can be used to move the body. There's several different types of exoskeletons. There's orthoses that can be used to help enable the movement, and whatever joints you want to connect up. You can have, basically your exoskeleton is a full body orthosis, or you can have your orthosis on individual joints. Now I'll go to the next one. So you can also use BCI actually for rehabilitation. And this is some of the more exciting work that's happening. Most of it has been done for stroke rehab. And they've had randomized control trials with stroke rehab. They've different orthotics that they hook up and that they are then using the brain signals and just the littlest brain signal in the right direction that they can then reinforce by making the body actually move in response to that signal. There are applications for this also for people with spinal cord injury. If there's anything residual there, you could reinforce it. Because essentially the brain-computer interface can bypass that spinal cord lesion and go and activate the body part, but also reinforce the efficacy of what the body is trying to do with what control or partial control it may have. It's not really there yet for full body walking though. The best I could find on the exoskeleton, other than fancy pictures of this is what we want to do, was that they've been able to have the exoskeleton that's BCI operated walking after spinal cord injury and with the exoskeleton suspended from the ceiling. There's some serious balance issues here that are really complicated to figure out for these kinds of applications. So I also had, I was talking about the motor imagery as the signals to operate a BCI. And I'll figure out how to start the video running here. So this video is supposed to be the imagery of the brain signals that the person is controlling. And here is the a person in the cap. And this picture is from this video from 1998. But they are thinking to operate the position of that hand. So again, when we're talking about, what's the timeline? We've been able to do some of the simple things for a long time. It's very hard to get it out to the point where it's usable and effective. I'm finding that in the little niche that I've made my own, is that it's very hard to get it to the point where it can be used independently in the home. So this was a gentleman with spinal cord injury who was concentrating on opening and closing the hand, and without any actual physical movement. And let's see. So there's also the question of how are we getting these signals out? This is a lot of what has been done is either done with EEG, which gives you very low resolution signals. It's hard to do anything quickly with EEG, and it's hard to do anything very precise. You can tell whether you're trying to move your left or right hand, but trying to tell apart different fingers or something is very hard, because it's kind of like trying to listen to me from out in the hallway. You might be able to hear that I'm speaking, but what am I saying? It's, you're outside this room. When you go putting electrodes inside the skull, you end up with much better recordings. You've got the person inside. And so I am going on and on. Okay, less on that. This is another method. This is the BrainGate microelectrode and implants. And this is actually going into the brain itself, but they don't have it wireless yet. They've got a pedestal sticking out the top, and they've got some really cool videos though of what they're doing. This is also signals where I think the record is somewhere around 7 or 8 years. I saw the announcement when they hit the 7-year mark that they'd had somebody they were recording with for 7 years, but that was about a year ago. So if they're still recording with that person, they're up to about 8 years. One of the things about knowing whether, there we go. Was that the same one? Okay, well then we'll just speed through that one. So there is some potential to automate functionality. You know, I was talking about the speed and balance and things. Maybe we can automate that, balance and gait. It should be fairly easy to say, let's not have the system fall over. But there's also some very exciting work being done with restoration of feeling. You know, skilled motor function requires knowing what you're doing. And one of the tests that they've been running with this is to have people try, I think they're holding a little cherry tomato there. But they've also been working on systems where they can give people like a big cherry and have them try to pull the stem off. And that's a difficult thing because you don't want to make cherry juice by squeezing too hard. But if you don't squeeze hard enough, you can't separate the two tasks. I loved this quote, for my prosthetic with no sensation is a tool at the end of my arm. With sensation turned on, it's my hand. Now this is being in clinical studies at the moment. Of course, there's challenges there, rapid production of sensation, what's natural, can we repeat it? And when you're talking about implanted projects, go read about the freehand system that they released in 1997 and then the company closed. And there were people without any kind of support. So if we had more time, we would discuss what kind of input is desirable for prosthetic control. Talking about communication, that's the area I'm in. So this is where I could talk forever. I can talk forever and just about anything. But communication, you know, we talk about thought to speech as our holy grail if we want to be able to do thought to speech communication. Nobody wants to know everything everyone else is thinking. We don't want the thoughts all to instantly go to speech.
Dr. Huggins?
Yes.
Hi, I apologize. I'm sorry to interrupt. We're going to have to move forward with our final presentation. However, Dr. Huggins' contact information will be included in the slides if anyone has questions.
Okay. They're doing some really cool stuff with the implants and communication too.
So I first want to say thank you very much for inviting me to present today. I have thoroughly enjoyed listening to the wide variety of presentations of incredibly intelligent people who are doing amazing things in this space. My work is more on the health equity focus. I am specifically interested in women's health, and most specifically, I spent my life in trying to figure out how to prevent cervical cancer. What I'm going to share with you today is work that we've done here at Michigan with underserved populations. I've called it narrative barriers to cervical cancer screening because that is where the emphasis and that is where the value of the work is that we are going to share with you. I'm particularly focusing on a grant that we just got funded. It is specifically looking at Native American women and looking at Black women. And so what I'm going to share with you in the background information has specifically to do with those two ethnicities. In Indian country, they call it ending cervical cancer is important. They have four different pillars. One is getting vaccinated. One is looking at how to practice smart sex. One is to stop smoking. And the one we're going to talk about today is getting screened. I think it's very important to see that the Native Americans have this put out in a very simple format. What we know about our Black women is that cervical cancer disproportionately kills them. There is an 82-page report that says we need access, ending preventable deaths from cervical cancer in rural Georgia. Specifically saying cervical cancer deaths aren't just a tragedy. They reveal systemic exclusion from life-saving healthcare and information. Rural communities face great difficulty just getting to a doctor, and the stark racial disparities in outcomes shows a clear pattern of discrimination and neglect. So what I'm going to present to you today is the work that the Harper Lab has been doing in self-collection for HPV testing, which is the next cervical cancer screen that we will be using in the entire population. We have two different ways of doing self-collection. The first is called a vaginal collection device. We are specifically looking for human papillomavirus, HPV. This top one that you see that's in the Barbie bright pink is what we call the Rover's Evelyn brush. The second one below that has a little red tab on it is what we call the Flock, F-L-O-Q, Flock swab. Both of those are approved in Europe, have the CE mark for primary cervical cancer screening using HPV testing. What you see is the instructions for how to use this. You start by washing your hands. You take the device out of its container. In the particular case of the Evelyn brush, you take off that big pink thing that's at the end of it. You then have access to the swab. You insert it into your vagina just like you would a tampon, and then you plunge it in so that the little bit that's sampling actually goes into the vagina. The vagina is a closed space, so it's not like you have to move it very far in order for that device to actually touch the vaginal walls. HPV has to be on the vagina before it can be on the cervix, so it's actually a superior method of being able to collect HPV. You see in step 6 that after you're done, you pull it out, and then you pull this sample right back into the tube, and you put that in step 7, that great big pink cap back on it. You put it in the package and you mail it back to us. It's very simple. So with that is one option. The other option for women who feel that they don't want to touch their vagina, that their religion precludes them from using a vaginal swab, or one where they're just scared of touching their body, allows us to collect a non-clean catch urine specimen that takes the cells that are falling off of the vagina and fall out of the vagina every time she goes to the bathroom. This is particularly looking at collecting that first 20 cc's at the time that she sits down to void. This is collected in a device that fits up tightly against the woman's perineum, and that it allows her to start her stream, so she doesn't have to figure out where is it going to come out, if it's going to come out. And then she looks at allowing that to fill. It automatically switches with a one-way valve to dispose of the rest of the urine into the toilet. And then she can disengage the tube with the urine in it for sampling to send to the lab. Again, that can be mailed into us. And the collection device that she used can then be thrown away in the trash. So what I'm going to share with you now is results from prior studies that we have done among disenfranchised women without up-to-date cervical cancer screening. I'm going to start by talking about barriers, women who have barriers. When we asked women what kind of barriers they had to cervical cancer screening, 32%, a third of them, said they had no barriers at all. They just didn't want to get screened. 39% had multiple barriers, many, more than one barrier. And the rest of the sample, about a third of them, had single barriers that meant they did not want to get screened. The most common one was that it was uncomfortable with the pelvic exam. When we look at what are the reasons for women who have more than one reason for not going in to have a cervical screen done, we see again that being uncomfortable with the pelvic exam was the most common cause among those women with multiple barriers. So we tried to figure out what are the attributes of cervical cancer screening techniques. how can we measure those and how can we identify them? We started with focus groups of women to develop a list of unique attributes of the cervical cancer screening technique. We then ordered the attributes presented for the response that was tested. We finally came up with the questionnaire that whittled it down, narrowed it down to only 14 attributes. 3 of those were positive and 11 were negative. We intermingled the positive and the negative amongst themselves to try to get a better representation when we asked women in the surveys. This is a very, very busy slide. I'm going to cover up half of it for you so that you don't have to see so much at once. But what it shows is all 14 of those attributes. What you see right now are 3 attributes on the far right-hand side of the screen. Those that are in blue are pelvic exam rankings, and those that are in yellow are the vaginal exam rankings. These are rankings of the attributes on a scale of 1 to 5, where 1 is not at all and 5 is very. So when we talk about, is the pelvic exam quick? You can see on the very far right-hand side in the blue line that it was kind of medium. But when you ask the vaginal exam, was it quick? You can see it skyrocketed up there. It's like, yes, very much so. The same thing for easy. The pelvic exam, not so much. The vaginal exam, very much so. And empowering. Why would a cervical exam be empowering? But if it was done with the pelvic, it was definitely not empowering. But if it was done by a vaginal self-exam, the woman felt empowered. These are all statistically significant at the less than 0.001 power. All right, this one gets a little busier because these are the 11 negative attributes of screening by the screening technique. These are women with at least 1 barrier. And what you see uniformly across here is that, remember, they're negative attributes. They're things like complicated, intrusive, annoying, stressful, icky, gross, vulnerable, embarrassing, painful, uncomfortable, awkward. These are really not good things. And the pelvic exam was ranked as very. It was high. Look at those high blue lines. Whereas the vaginal self-sampling exam wasn't 0. It didn't have none, but it had so much less. It was much, much less. And again, these were statistically significant. So these are for women who've had at least 1 barrier. So now you say, yeah, but a third of these women who were underscreened and disenfranchised didn't have any barriers at all. So did they care about what technique was used? And what we see here are the only ones that were significantly different. And again, you see that the blue columns are so much higher. The pelvic exam was so much worse than the vaginal self-sampling exam, even among women who have not been screened, but claimed they had no barriers to screening. So this says, that's interesting. Those are numbers. Those are statistics. That makes sense. But what do women really think? And this is what I'm going to share with you next. In their words, I hate going in for a pap smear. So self-sampling, was perfect for me. I would do it this way every time. I feel like it was a huge, huge deal to me to be able to do it at home in my own privacy when I was comfortable, as opposed to going to the doctor's office with the doctor and the assistant in the room. It's like completely uncomfortable for me to do it there. And this made it so much easier for me. I wasn't anxious about it. I just, got it done. I didn't have to worry. I get scared and stuff when I go to the doctor and self-conscious, so I avoid having it done. I want to get screened, but I don't feel comfortable going in. I had a doctor ask me if I was enjoying myself, and that just put me right off, He said it looked like I was enjoying myself, and I was just staring up at the ceiling. And that made me very, very uncomfortable. And it stuck with me every time I had to go in and do it. Doing it myself is so much better. It's not intrusive, you know. It's so much easier, and you don't have to put your feet up in the stirrups. I struggle with PTSD. I was sexually assaulted. So there's always that little bit of anxiety of going in and doing that with someone you're not 100% comfortable with. And my doctors never explain to me what they are doing. It's like you come in, you spread your legs, they do their thing, and you leave. What are you doing and why? And why is it important? I never get any of that answered, and they don't offer that information. And a lot of women are so sick of being there for an hour anyways. And you don't want to ask questions, or you're embarrassed to ask the questions. So I think this is wonderful. I like the fact that I can do it myself. It's less invasive. And then the fact that I can do it at home is obviously a comfort. You know, you don't have to make an appointment. You don't have to work around your schedule. You don't have to use your, I don't know, lunch break or whatever to make an appointment to go in and do this. It's just you, and you're at home. You mail a box, and it's incredibly simple. Well, this wasn't something I was planning on getting done anyway, but because it's so very easy to do at home, I did it. I wouldn't have done it if I couldn't do it at home. So I think these show us examples of what women who are not getting screened are saying. They're telling us, they're trying to say, help. We want to take care of ourselves, but we're not really able to do that. We have a lot of misperceptions. These are two quotes that make me, as a physician, particularly sad. One is, we all go to the GYN. We all have to suffer through the same things. We just do what we got to do for our health. And the other one who says, I think when it comes to making sure that it's done right, I think that even though it's embarrassing, I would rather have my healthcare provider just do it to make sure it's done right. So I'll just bear the shame, you know, for like a minute or two in order for it to be done correctly. Well, first, there's a misconception that the GYN or that whoever's putting a speculum in to do the exam is going to be more accurate than you are by either doing a vaginal swab or doing a urine collection. That is not true. We have multiple studies of hundreds of thousands of women who have done these tests, and we show that self-sampling is not inferior to clinician-directed sampling. So there is an educational component that goes along with this. There's a power dynamic as the physician's like, yeah, but I want to do it because I'm better, and I want you to know that I'm better. And that power dynamic cannot remain. We have to suck that power dynamic. So I am going to ask you for help. We are trying, I told you, we have this study that we have funded. We need women now to come tell us what they think. The aim of this work is to evaluate the barriers and experiences of Black and American Indian and Alaska Native women with physical disabilities, specifically physical disabilities. Women with physical disabilities are half as likely to undergo cervical cancer screening and therefore are more likely to have late-stage disease at diagnosis with higher mortality than women who are not disabled. Black or Indigenous people of color, BIPOC, have 2.5 times the rate of physical disability than white women. Furthermore, compared to white women, BIPOC women have twice the rate of developing cervical cancer and 4 times the rate of dying. Cervical cancer screening has evolved from cytology alone through co-testing now to primary HPV testing with a reflex test for non-HPV 16 or 18 positivity. Primary HPV testing does not require a speculum exam for sampling. Therefore, self-screening with vaginal devices or non-clean catch urine are options for women with physical disabilities or their caretakers. We know that American Indians and Alaska Natives cite a number of barriers to cancer screening, such as cultural reluctance to access Western medicine for non-acute health problems, transportation difficulties, lack of childcare, negative perception of health providers, long waits for appointments, poor patient-provider communication, provider time pressures, and an underfunded healthcare system. That sounds like a lot of the comments that our other women who were disenfranchised told us. It really sounds like the same kind of issues. Prior Harper studies have shown that the most salient barrier to cervical cancer screening is the pelvic exam technique among other under or unscreened populations. So our study design is, with discussion with the community partners, will establish the most appropriate way to deliver and collect home self-sampling kits for primary HPV testing. Will be both a combination of urine and vaginal kits. They'll have a written survey about their experiences and beliefs about cervical cancer screening, a written survey about using the kits themselves, and then we will have an oral interview, either by phone or by Zoom, whatever's comfortable for them, about cervical cancer screening experiences that will be recorded and transcribed and analyzed for thematic content. There is an incentive. We do offer women some money to be able to do this. We know their time is valuable. And we will discuss with the community partner afterwards the procedures for women who tested positive for HPV on how to get them the secondary help they need for the next follow-up steps in their workup. The population we need: Black, Native American, or Alaska Native women with a self-defined physical disability. They have a cervix, they're 25 to 65 years old, and they're not currently pregnant. And if you have access to women or want to make women know about that, please have them reach out to me, either at my personal email or at our lab's email address. I appreciate the opportunity to share this with you. I hope that we will be able to enroll women who would like to tell us about their experiences with cervical cancer screening as they help us learn how to better reach our population. So with that, I thank you very much.
Thank you very much, Diane. I know we're running short on time, so I'll let folks contact you if they have specific questions. But I do think that you and all of the presenters today have really highlighted the wealth of really important research going on here at the University of Michigan, the important programs and their applicability to our folks with spinal cord injury. That was the objective of today's session, to really enhance awareness about what is going on. But of course, this was only less than half of it. As you could, I think what we have seen really reflects on the dedication and commitment of clinicians, faculty, staff, who give not only their professional time, but their weekends and evenings to create programs that they think are going to make a difference in people's lives. And I think what we need to do is keep supporting one another with this process. I think despite the technical difficulties in trying to manage the hybrid format, that this event is a milestone. Because if we want to improve outcomes, we need to be able to translate between what goes on in the clinics, what programs are being created, and what research is out there. What we learn in research has to go back to inform our best practices for a clinic, to inform recommendations. We need to know about the programs you're doing, about the opportunities. We need to figure out how to support them, given research funds, or how to keep, working together to enhance the quality of life and outcomes for our patients. That's what this is about. So thank you, everyone, for your willingness to come here and spend these hours with us. If you did register for the conference, please make sure you go back in and claim your CME credits. Once again, we have both the continuing medical education credits as well as APA continuing education credits that are available for participation in this conference or in this symposium. We have descriptions of the various grants here through CDHW in the back. And I believe there will be an evaluation of this program sent out in the next week or so. we'll have recordings or the recordings that were created online, edited out the additional time for in between as we were handling things, but this is an important start. So thank you.